Hi, I'm Dr. Donald Jurovich, Professor of Geriatrics at University of North Dakota. Today, we'd like to talk about dizziness. Our objectives are to describe why dizziness occurs in older adults. I'd like to talk about the evaluation of older adults with dizziness and syncope, and then its treatment. Topics covered include classification and causes of dizziness, as well as the evaluation and management of dizziness in older adults. So the importance and complexity of dizziness is most importantly that it's a common condition in older adults. Various prevalence and epidemiologic studies suggest that the occurrence of dizziness is from 4 to 30%. It certainly increases with age, and women tend to be affected more than men, and oftentimes, as we will see, it's multifactorial. So there's a lot of challenges related to dizziness. The precise classification is often elusive. Specific therapies, such as antivert or meclizine, are not always working very well. And so there's not many specific therapies and really not a lot of research either that's moving ahead with treatment of dizziness. And then the other problem is that most of the cases in older adults have multifactorial etiologies. So I'd like to really divide or think about dizziness in terms of an acute episode versus chronic. And so the acute dizziness is independent of age generally. It usually results as a disorder from one system as opposed to the chronic condition, which is multifactorial. And some of the more common causes of acute dizziness include acute vestibular neuritis, cerebral vascular ischemia, and various cardiovascular disorders that often result in hypotension. By contrast, chronic dizziness is something that usually occurs for greater than 1 to 2 months. It is more age-specific, being more common in older adults. It has multifactorial etiologies, and it's really more or less considered a geriatric syndrome. And it takes a multifactorial approach and to focus also on medication side effects as an underlying etiology. But chronic dizziness really has some considerable consequences. It's associated with increased fear of falling. It can be associated with depressive symptoms, fall risk, and just general decline in functional ability. So the important point is that vertigo is never continuous. It's there is, even with structural lesions, adaptation and habituation, which can occur in weeks. And so if you have somebody that considers their dizziness or vertigo as persistent, ongoing, unrelenting, generally that has a psychogenic underpinning. So that's an important distinction. And just also to mention the fact that there are adaptive processes in habituation, you can use that actually as part of your treatment intervention, where you try to reproduce the positions that induce vertigo under obviously more controlled conditions. You don't want to be flying an airplane when you're doing habituation therapy for benign positional vertigo or other types of dizziness. But the point is that if you can find a certain position that causes the dizziness, that recurrent positioning, it will help reduce the symptoms of vertigo and dizziness. So if we try to classify dizziness according to symptoms, we have true vertigo. So this is considered to be episodic spinning or a rotational motion where either the person or the environment rotates. It could be either or. By contrast, there's presyncopal episodes where you have this sensation of you're going to faint or you feel lightheaded, and those are often the words that people describe. There's a disequilibrium syndrome where you feel off balance, either when you stand or walking, and sometimes presyncope and disequilibrium can cross over. So if somebody gets up out of bed and they say, oh, I felt light in the head, but then I felt like I was going to fall back, then we have to sort out which is which, and we'll talk about things like orthostatic blood pressure check as one of those mechanisms for evaluating the differences between presyncope and disequilibrium. And there's somewhat of a catch-all term of all other forms of dizziness. These include the more vague feelings such as floating, again, lightheadedness may be used to describe that, a wooziness, and other nonspecific sensations. A mixed dizziness syndrome would be a combination of two or more of the above, and that actually is the most common type. So that's why it's such a challenge to deal with dizziness. So in terms of vestibular-specific disorders, include benign paroxysmal positional vertigo, Meniere's disease, idiopathic recurrent vestibulopathy, acoustic neuroma, and cerebral vascular disease. So it turns out that the absence of spinning sensation does not automatically exclude vestibular disorders, because patients with actual vestibular disorders might describe their problem as more of an imbalance or a disequilibrium or other sensation. So that's why we have to go through a somewhat structured physical exam and figure out what the underlying pathophysiology is of the dizziness sensation. So in terms of benign positional vertigo, it most often presents as an episodic. It'll occur with change in head position. So if somebody's in bed rolling over, or if they gaze up at the sky or look down, those can all be precipitating moments. They can be sudden, generally seconds-long bouts of vertigo. And most likely they result from a dislodging of otoliths in the semicircular canal. And you can see on the diagram to the right a stained cross-section of the semicircular canal with little dark stones there circled in red that are otoliths. So here we have Meniere's disease, and for those who are wondering what he looked like, there he is in person. From the 1800s, he was I don't know if he was a protege or an associate with Dupuytren, another French physician of fame for Dupuytren's contractures. But Meniere never really reached full professorship, as was his career goal, and he, I guess in some respects, was banished to a deaf-mute institute where he wound up describing a disease that's named after him. So it's considered idiopathic. Meniere's disease has repeated episodes of tinnitus or ringing in the ears. There might be fluctuating hearing loss with a sensation of fullness in the inner ear, and it can be associated with pretty severe vertigo. Turning towards non-vestibular issues is presyncope. This is a sensation of faintness or lightheadedness. It often is associated with decreased cerebral perfusion and is precipitated by postural changes, such as getting dizzy on a stand to up from supine position. And it may occur with or without measurable orthostatic hypotension. Also common in frail, diminutive, older women, typically frail, again, older adults, is postprandial hypotension. And you can see in the diagram here, in this graph, that there was a large caloric challenge provided to patients, and you can see the immediate drop here in the blue of the systolic blood pressure. Not so much with the diastolic, a little bit, but primarily in the systolic blood pressure. And you can see that it occurs within 30 minutes. There tends to be a little waffling after the first hour, but then there's a persistence after 2 hours. So the take-home message is that if you ever request orthostatic blood pressure checks on older adults postprandially to rule in or rule out this condition, it's important to do it within 30 minutes of eating or an hour to 2 hours after eating. So disequilibrium is another condition of dizziness that we need to talk about. It's a sensation of imbalance or unsteadiness. Here, there's many factors that contribute to imbalance, sometimes vision problems, proprioceptive disorders, particularly as we see in paresthesias with diabetics, also in musculoskeletal disorders, as well as various gait disorders, such as you might see with normal pressure hydrocephalus, where you have that antaxic, wobbly, drunken sailor-like gait. And I just want to bring your attention to this picture about bifocal lenses or progressive lenses. Really one of the more evidence-based findings recently has been for older adults that fall is that they should wear distance glasses alone while walking and not to use bifocal or progressive lenses because of the blurriness that occurs that when they look down during the fall, they can't really compensate very well. So sort of the catch-all for dizziness are the other forms. And again, the patient may describe a variety of symptomatology. A lot of times there's a psychiatric cause that can be associated with depression and anxiety. And also mixed forms of dizziness. So those basically are a combination of two other forms of dizziness, such as hypotension or disequilibrium. This is the most common type reported by older adults. And it may be a combination of etiologies that involve some vestibular components, some central nervous system components, and visual or proprioceptive problems. They often are accompanied with systemic disorders, multiple medications. And then finally, you need to consider carotid sinus hypersensitivity syndrome as part of this differential diagnosis for this mixed dizziness condition. So some of the culprits for dizziness are, as you might imagine, medications. These include anxiolytics, antihypertensives, particularly loop diuretics, antidepressants and antipsychotics, well known as the ototoxicity of aminoglycosides, high-dose nonsteroidal anti-inflammatories, often associated with tinnitus, as well as antihistamines and the infamous anticholinergics. So some of the characteristics of dizziness in older adults is that when it occurs, it usually will resolve within days to several months. It can be chronic or recurrent. Again, it has multifactorial etiology. A lot of times it'll be associated with postural hypotension, and in one study, presyncope or syncope actually was found to be associated 25% of the time with postural hypotension. But also, many times the older adult will have anxiety or depression that accompanies the dizziness. And certainly the use of 5 or more medications, which by definition is polypharmacy, is also associated with dizziness. And it may not be surprising that a lot of these folks will have impaired gait and balance. So I'd like to move on to the evaluation of dizziness, and the history is critical. It's important to have the patient describe in their own words without much prompting as to how they would describe their condition. And then you want to ask them more about timing, what provokes it, and what will exacerbate it. And finally, to find out how these symptoms are affecting the individual's function and quality of life. So does it really take them out of action, or is it a mild nuisance? So you want to try to establish the range of functional disability that this is causing. So in terms of timing, looking at the history, you want to find out whether it's prolonged severe vertigo and versus recurrent spontaneous attacks or chronic persistent. So if you can get a sense of the timing between these three possibilities, the prolonged severe vertigo would be more suggestive of vestibular neuritis or stroke, things such as migraine headaches that are associated with vertigo or presents solely as vertigo as opposed to head pain. And then the recurrent spontaneous attacks would be more Meniere disease or also migraine. And then the persistent or chronic dizziness would be more associated with psychogenic problems and possibly cerebellar disorders, so cerebellar atrophy, tumor, and so forth. The other part of the evaluation is to find out what provokes the dizziness. So spontaneous is, as stated, occurs without any known causes. Some people say I rolled over on the right side of my bed and the right side of my head, and I started getting dizzy. And every time I do that, I get dizzy. So that's positional. And then also individuals that say, oh, I get up out of bed and I have to sit for a while before I stand up because I feel lightheaded. So that would be a postural associated condition. So here we have the third element that we want to ask about is whether aggravating factors such as understanding that if head movement causes the vertigo to be worse, then it's more likely to be vestibular oriented condition. So some of the key features of evaluating dizziness include orthostatic blood pressure and heart rate. Just want to caution you that if somebody is on a beta blockade, their heart rate's not going to change a whole lot from the supine to upright position. You want to do provocative maneuvers and watch the eyes for nystagmus. I simply just do a cross-check initially of having the individual follow my finger in pursuit, because sometimes you can see changes in saccadic rhythms as well as beating nystagmus, which clearly if you bring the eyes to the fullest extent laterally, there is physiologic nystagmus, so that doesn't count. But if you start getting nystagmus with a 30 degree rotation of the eyes, or if you see, and we'll see a video of rotatory nystagmus, those are always pathologic. You want to check both ears for fluid, certainly cerumen impaction also. In terms of cardiovascular, you want to auscultate for bruits. It's important to listen for aortic stenosis murmur. I also like to include a shoulder shrug and cogwheel test. The shoulder shrug, if weak or central weakness, often may represent conditions that can cause central muscle weakness, such as metabolic disorders with hyper or hypocalcemia, as well as polymyalgia rheumatica as some key examples. And then finally, it's important to observe for balance and gait difficulties. So we like to do the Sharp and Romberg, where if you put one foot in front of the other and see if the individual can hold that for at least 10 seconds. And other maneuvers, such as the timed up and go test.